everyone. Welcome once again to the Sunday Office Hours, which is a joint project of Healthcare for All, PNHP California, and many of our other partners in the healthcare justice movement. We're really happy that you've made it with us once again. I'm a co-host today with two other co-hosts from the Progressive Asian Network for Action, and that is David Monkawa and Taiji Miyagawa. We always start the meeting off with reading the CalCare principles. Healthcare for All. So Paul, if you'll put those up, I shall read them.
All right.
Okay. CalCare is California Guaranteed Healthcare for All. It is the solution to our broken healthcare system. It will guarantee healthcare as a human right in the state of California by providing comprehensive, high-quality healthcare for all, just like Medicare for All would do nationally. These are the core principles of CalCare. Universal coverage, that is everyone in, nobody out, regardless of race, sex, gender, country of origin, disability status, immigration status, marital status, age, and income. Everyone gets the care that they need regardless of ability to pay. And when it's universal coverage, that means we all get the same quality of care and the same access to exactly the same care. And that would be a single public program. We want a single payer, publicly funded program through progressive taxation to cover all necessary care in California. That eliminates billions in bloat and waste and saves people thousands of dollars on their healthcare costs. It also saves the state. As we saw in our last effort 4 years ago with SB 562, we realized that the state would save $27 billion a year. And that was a conservative estimate. And everyone in the state would save out-of-pocket costs. So we know that a single public program provides significant savings by reducing those administrative costs that are so unnecessary. CalCare provides fully comprehensive benefits, and that includes medical, dental, hearing, vision, mental health, prescription, long-term care, and more. All decisions about care would be made between you and your doctors and nurses, not insurance companies, no intermediaries requiring approvals, requiring permission. We want to return the practice of medicine and the practice of healthcare to healthcare professionals. We want to put the care back into the healthcare system. And that means removing the business interest from deciding what we all get for our healthcare. It has to be returned to the healthcare system and healthcare providers who have trained professionally and who are educated about what we need. CalCare provides the freedom to choose your care provider. There will be no more networks, no in-network, out-of-network. There are no networks. You would have the freedom to choose any doctor or hospital you like. And that would have a consequence beyond just our personal choice. And that is those that do a good job would have more patients signing up to be with them. And those that are doing, less quality work, maybe not doing the quality that people would want for their healthcare, those providers would probably be encouraged then to do a better job to assess their practices and make sure that they were providing really high quality care to their patients. CalCare is free at the point of service. No more copays, premiums, or deductibles. No out-of-pocket costs. You arrive at the doctor's office, you show them your CalCare card, and you get the care you need. It's just that simple. It's also from birth to death that these services are provided. So anyway, Just Transition is some funding and programs to protect and support any displaced workers in the insurance industry. The CalCare document does allow for a retraining. It does allow for some compensation and it does allow for priority placement for the new jobs in healthcare. And there will be many, many new jobs with an implementation of AB 1400, because we will need many more people actually providing care, and rather than denying care. Our tax dollars and our personal, well, will all be tax dollars. All of our tax dollars will be spent in a service of providing care, not restricting care. So patient care will be based on patient need. There are no more financial incentives to avoid providing necessary care, including value-based payments for models for providers. Physicians will be free to practice to use their medical knowledge and to practice with their own autonomous judgment. Right now, the professions have pretty much been hijacked by insurance industry, which is determining what care physicians are allowed to provide for patients. So we want to return the practice of medicine to those who are educated professionals in the field of medicine. So those are the CalCare principles. And now we will, I'd like to introduce our guests, our guest hosts, David Monkawa and Taiji Miyagawa. I'm introducing them as a pair because they were both lead organizers in a campaign called Save Our Seniors, a really important campaign that we believe the campaign was a success. AB 279 was the legislation that would have provided the Save Our Seniors requirements, would have provided what was needed for the senior population. The bill passed, and David and Taiji are going to explain to you exactly what happened. The bill passed. It passed with flying colors, both legislatures, but it was vetoed by the governor. So the bill itself and the campaign itself, in our view at Healthcare for All Los Angeles, was a success. What is not a success is our political system that allows a single person to override the representatives of the people. So I'm going to turn this over to David Monkawa and to Taiji Miyagawa to tell us all about AB 279. Oh, one other comment about it. AB 279 relates to AB 1400 because the issues and the problems that were being addressed by AB 279 would not exist in a system like CalCare. We wouldn't have to deal with these issues and problems of inequality and allowing the most vulnerable in our population to be left without the care that they need. So I'm going to turn this over to David and to Taiji.
Thank you, Maureen. I don't know if my colleague Taiji is on yet. He said that he had some business to do, so I'm going to kind of wing it until he gets on. But first of all, AB 279 was a piece of legislation that was sponsored by Miguel Santiago and Al Muratsuchi. Santiago in the 53rd Assembly District here in Los Angeles, which covers Boyle Heights and Lincoln Heights, and Al Muratsuchi in Torrance covers another facility in Torrance. That would be the Pacifica's KI South Bay facility, another nursing home. There's 3 nursing home campuses. And upon those 3 campuses, there was approximately 300 Japanese Americans at the time that it was sold. It was sold to a big developer named Pacifica. And this developer, Pacifica, who now owns the nursing homes, wanted to move out the seniors in the intermediate care facility in Boyle Heights. And they had acquired the property and continued to develop it. So they were also gentrifiers within Boyle Heights, and the neighborhood was already aware of that. So now they want to shut down the ICF, move out approximately 80 seniors in their 80s, 90s, and 100s. Their attending doctors, all 10 had signed a letter saying this would be very, very, not only disruptive, but potentially deadly because they're too old, they're 90. A lot of people won't survive more than a year, the doctors warned, but they did it anyway. The bill was supposed to stop the eviction or transfer of anyone from residents of nursing homes during a pandemic. That's what the actual bill was supposed to do. And what happened was that as the bill made its way through the legislature, Pacifica started to hurry up the eviction process by doing things like, by strange coincidence, there was a horrible water foul up where the hot water was broken and old people couldn't take showers sometimes. Or there was like bad food all of a sudden. Or there was a threat made at one point where one of the administrators told all the residents that, if you don't move out by the eviction date, there may not be any staff here to take care of your parents and take care of you. And they accumulated 5 citations from the County Department of Health for various violations that were all coincidences, apparently, after the eviction date was set. But despite these fines, not fines, but despite these citations, which are basically just a slap on the wrist, as people know, nothing happens to them. They went on their merry way and they evicted them. Now, the way they did that was the legislation itself, we were very confident because it was very strong. It had great bipartisan support. I think it passed the Assembly by 33-1 or something like that. And then it passed the Senate too. But when it got to the governor's desk, Cassie Dunham, who is a assistant director at the California State Department of Health in Sacramento, lobbied to veto AB279. And the argument that they advanced was that if AB279 were to pass, it would be a financial burden on nursing homes because, they would not, some of them would not be able to transfer people when it was needed and they can go broke. Well, we knew that was just completely, wholeheartedly, BS, because that was not what was going on in Los Angeles. They were going to, their very well-financed outfit, they were going to shut it down. They have 2 other campuses, and all of their 41 facilities in California are all private paid. And of their 41 facilities, many of them used to take Medi-Cal before. So we know that this company is going to try to, eliminate all the Medi-Cal people. So anyway, we were very disappointed when she was able to convince the governor and he signed it. So we found out that, California Department of Public Health directly speaks with the California Association of Health Facilities, CAHF. That's the main industry lobby for nursing homes in California. And their leader is named Craig Cornett. He used to be one of the legislative assistants, and he used to be one of the people doing work in Sacramento, and that's why they recruited him. Many of these people in the industry, the nursing home lobby, they go back and forth between private industry from nursing homes or hospital outfits that they came from and the government. And we see the same thing with the defense industry, how they go back and forth between Lockheed Martin and the government and so on and so forth. Same thing with environmental movement. So that's what happened here. And, the Japanese American community was absolutely livid and upset. There was a very passionate letter that was went out, to newspapers and to all the elected officials, essentially saying that, Newsom sided with the insurance lobbies. He sided with Pacifica and the developers against elderly people. Unfortunately, some of the elderly Japanese, when they were young, they were evicted and moved out and sent into concentration camps during World War II. And now, as they are in the twilight of their years, they're now being evicted probably for the last time to spend it in a nursing home that does not have bilingual, bicultural care or any of the other food and things that they were used to. So that's kind of like a story that's been repeated many, many times in California and the United States to many, many peoples. And I think that as unfortunate it is that the Japanese American community had to endure this, we made many new allies, many people who are in the same kind of situation in the Latinx community and African American community. And we also met many people, who are committed to working on correcting these kinds of things. So now we're going to have a program, we hope, that talks about the future and how we're going to have long-term care in the Japanese American community and everybody else's community with AB 1400. So as far as the AB 279 part of it goes, I kind of wanted to, solicit any kind of comments or any opinions or questions that people have about what happened with AB 279. And I see a hand up with Dr. Bill.
Dave, I just was hoping
Yes.
that you could turn on the chat so that we could communicate. The chat's been turned off. Is there a reason for that?
I don't know. I don't know how to control it, but I see the chat in front of me.
That's Paul. Paul, the chat's on, correct? My chat is on.
Yes, the chat is on.
Okay, thank you.
Mine says
Really?
no.
Chatting with me. There's
I
people
just
chatting
wanted
with
to recommend that there's a Pulitzer Prize photographer by the name of Renee Byers, who is a photographer here at the Sacramento Bee, whose husband just did a book called The Hand of Barbed Wire, where he did this extraordinary photographic series of the Japanese community that was incarcerated when they were children and now when they're grown up. And it's absolutely stunning. It's in the California Museum, but I think they would be tremendous allies, tremendous media allies for you. And they would jump in a heartbeat in order to work with you in any way you want.
Great,
And I
thank you.
give you Renee's, her husband's name is Paul. Let me just, God damn it, get you a phone number here real quickly. Her phone number is, oh Christ, just a minute. That's why.
Why don't you just write it in the chat
Exactly.
later on?
Exactly.
Okay. Are there any other comments or questions people have about this bill and why it went down?
Well, if not about the bill, I think we
I
can
do.
talk about the dangers of having private for-profit nursing care facilities. During COVID, we saw that the profit-driven decisions really exacerbated the COVID situation rather than improving things. We saw that in for-profit nursing homes, they were up to 6 times higher rates of COVID than in nonprofit and government-run facilities.
Yeah.
And maybe David, you could tell us some of the things that some of the sort of strategies, I guess you would call them, that these facilities use to maximize their profits at the expense of the health and well-being of the residents.
Sure, I could. Can I put on a screen share here with?
Yes.
Okay,
Yes, you can.
how could, it's a challenge to do this, but okay, first I click on the share screen, right?
Right.
And then do I have to click on something that,
Paul, can you give advice there?
how do I do this? Okay, so I put on the screen share. Can you see that?
No. Paul?
What
Can
you
you-
do is you put on screen share.
Uh-huh,
There's a series of different windows.
uh-huh,
If you have something that's open,
uh-huh.
that's on your desktop, you select that and then click share.
Hi.
Do I have to open it?
Disabled. My chat is disabled.
Do I have to open the,
I'll find out why.
Yes.
We all have it. I'll find
Yeah,
out.
you have to open up the file that
Okay.
you want to share first.
I opened up the file, but I don't see it on the,
Now go to share.
yes, okay.
Are you close your share and then open it up again?
Close
There.
it and open it.
There
Do
you
see?
go.
Do you see it?
Yeah. Yes,
Do you see this chart?
yes.
I'm going to interrupt for one moment. Paul, the chat is disabled. A few people have called me
Yes,
telling me the chat is
Sumitra.
disabled.
Yes, Sumitra here. It's disabled for me as well.
You're muted, Paul.
Hold on, I'll check it out. If you want to share about your screen share, when you're ready.
I'm ready.
Go ahead.
Okay, so what do I do now? Screen share? It says you are screen sharing.
Already screen sharing. You just got to open the window that you're sharing.
Okay. All right. Can you see it now?
Yes.
Okay, good. Okay. So what I wanted to talk about was the what's happening at these facilities, Pacifica. One of the biggest things that we found out, and many of us already knew this, but you guys, many of you already know this, is that the reimbursement rates are very different, right? For Medi-Cal and for Medicare and for COVID. And so for Medi-Cal at Pacifica, the reimbursement rate's about $240. And for Medicare, it's about $620. So of all the people in the ICF, there's always a struggle to get in because people want to, if you're Medi-Cal, they don't want you in there. They really don't. So, as long as this thing is $240, they're going to try to kick us out. I tried to get my stepdad in there about 2 years ago, and I was refused. And then I found out much later that there was room, but they didn't tell me about it. And there's really no way to find out. But as you can see, as long as these reimbursement rates are $240 for Medi-Cal people, poor people, and $625 for others, they're going to always try to find an excuse to kick out Medi-Cal people or to deny them, right? So in other words, Medi-Cal people, they're poor. What nationality do you think they'll be? Well, we all know who they are, but so in other words, the numbers contain the discrimination. The numbers contain the discrimination. It's not like somebody says, I don't think I like people of color. That's not happening. These are numbers. It's silent. People are silent. There are nobody going around with any type of, racial discriminatory views. But is it systematically discriminatory? Yes, it is. That's what happened at Pacifica. Also, let me go on to the next little vignette here on the right-hand top side, the lack of bilingual, bicultural capacity and training. Well, these are two examples here that actually happened. In the first example here, it says, in broken English, the patient, psychiatry, he's saying that my mom hit us from the bombings each day. She hated soldiers and it rubbed off on us. I had to be a good model Asian student, even with our anger at the US. Well, these kinds of complex things are going on all the time. But unfortunately, the psychiatrists are not really trained for that, to deal with these kinds of situations. But this goes on every single day in every single city. Right next to it is another example that goes on. Here's a patient saying, my dad's side has sickle cell anemia. What do you think about my symptoms? What do you think they indicate? And the doctor, is kind of saying, wow, sickle cell, I heard like 15 minutes of it at med school. Okay. So that happens a lot. But, again, this is not the fault of doctors and healthcare workers. They're trying to do the best job they can. But it's the fault of policies and many other things that are decided. And many of the people who decide those things, they're good people. They don't have any kind of intent to cause harm to people of color, but they make these decisions. And in fact, it is discriminatory. Now, on the bottom left-hand corner, we have other examples. Here's a funding to research. Sickle cell anemia, 100,000 patients and 2.5 million people carry the trait. Cystic fibrosis, 35,000 patients. It receives 11 times more funding, 11 times. And these examples I just chose, I chose because they're good examples, but, there's many examples of where these came from. Going over to the right-hand side on the bottom, since the 1980s, priorities became increasingly profit-based, and as profits for the healthcare industry rose, unsafe patient care and avoidable hospital deaths rose. I think it rose to about 300,000 a year at one point in time. They did a bunch of things, hospitals and nursing homes. They used automation, robots. So they had computerized patient assessment programs and electronic medical records and these kinds of things. They eliminated some jobs. Guess what types of people were eliminated? A lot of women. Okay, then they have what they call JIT and lean production. JIT is just in time medical supplies and inventory for immediate service only. They learned this from automakers, believe it or not. They implemented it in hospitals nationwide. They had all these slews of books and programs and consultants, Lean Six Sigma for hospitals. And then they eliminated services and equipment with less return on investment, such as epidemiologists. You know, they make high salaries, so why don't we just keep enough on staff to get by? Okay, and that was before the pandemic. Hyperbaric chambers, they're for burns. And they're also for, like, you know, recovering people, skin divers who get the bends. Well, they're kind of costly and they take up space. Why don't we eliminate them? So they did that. That was before all the wildfires in California, where we now have, I think, 50 hyperbaric chambers for the entire state of California. Then they trained workers to be interchangeable for more flexible and compliant workforce. Now, when they did all these things, they weren't thinking, you know what? I think that we're going to take a swing at the people of color. They weren't thinking that. They're thinking of just making a lot more profit. But as we all know, all these kinds of measures that were done to increase profit, they all had a devastating impact on people of color and poor people in general, and on women. So, you know, these kinds of things are things that AB 1400, in particular, like the difference in the reimbursements and the bilingual bicultural care, AB 1400 would directly address those things. It's one of the only things, only legislation right now in the country that would do that. I think it is the only one that addresses bilingual care, and it'll do that. And that's why it's such a great piece of legislation. But as you can see, it'll take care of some things, but there's so many other things still that need to be taken care of, you know, like the educational things and things of that sort. But, you know, AB 1400 will be a great start, and it'll be a sea change.
David, Michael Pan has a question for you. Michael, can you unmute and ask your question?
Yes. I want to ask earlier, you mentioned about the bill that passed for bipartisan support for the senior bill. So I understand that it passed both houses at the California state level. Why did the governor veto the bill in the first place when it had unanimous support?
He believed the California Department of Health and Cassie Dunham, this one person in particular, who said that if this bill passes, that nursing home facilities will have financial problems.
Right.
You know, big financial problems, because they want to be able to transfer people out whenever they can, if they had to, in order to avoid going broke.
Right. And another question I have is because you saw about
they said that it's going broke because the reimbursements are so low.
So low. Ah, I see. Okay. And because I noticed in the description, the display sort earlier about the disparities in reimbursement rates for getting, like, you know, COVID relief, or even like hospital, or I'm sorry, for nursing beds. So very curious, like, how would the AB 1400, you know, address the disparities between, you know, private health insurance, Medi-Cal, and the state-based single payer? Because it says $240 and then $625. Is that $625 for the Medicare, or just $625 either patients who are on Medicare or patients who are on, like, private health insurance, or just the combined?
It's $625 to $670. It depends on the area and stuff like that. So it's not like hard and fast, but it's over $600. The main point is that it's 3 times more than what poor people are reimbursed. Okay?
Right. And if
you're asking so many questions, compound questions. But with respect to your question about you're talking about how would 1400 help that? Well, the CalCare board would take those rates and flatten them out, so that it wouldn't be so unequal.
Because I see the $830, you know, per patient, right? So that's $625. So that's $625 going forward to $825, or be closer to $825.
Well, again, don't get caught up on $625. It's not exactly $625 or exactly $240. It varies to a certain extent on place and region, really.
Place and region.
Yeah. But what's important to remember is that it's 3 times more than what poor people are reimbursed.
Right. I understand, because I understand that the patients on medical doesn't pay healthcare providers more, unlike Medicare and private health insurance? Because when you said that the pay rates will flatten, meaning
The
like
reimbursement rates.
right, or like flatten. So that means that some health providers will see an increase in their reimbursement rates, meaning like the ones who took care of medical patients before will probably like get a boost in payments, right? I'm just saying, like hypothetically speaking, because I understand it's
Well, it depends on your mix. I mean, you know,
Mhm.
you might get more on one type of people and get less on another.
oh, okay. Yes.
Basically, AB 1400,
Mhm.
it reduces a caste system. Like you're speaking about these different elements like Medicare, Medicaid, those distinctions would disappear. There wouldn't be any Medi-Cal, Medicaid, SHIP. Everyone would be in the CalCare system.
Okay, system.
And one of the things to remember is that everyone means everyone. There would be
Right.
no, no separate private insurance. It removes the insurance. The state becomes the insurer. And one of the things I tell people is that imagine if we all are in exactly the same system. I mean, if the governor and my state senator and you and I and the homeless person and somebody that's working in the auto industry or somebody that's working as a clerk, we all have exactly the same care and get exactly the same reimbursement for our care. Three things are going to happen. Mind you, the governor and you get the same care. So you'll have everything you need. It will be high quality and it will always be funded. The problem now with all of these divisions and how we look at, people, basically it sets a value on people. It looks at us as profit centers. You're either a Medicaid profit center, or you're a Medicare profit center, or you're a private insurance profit center. Your life is valued differently. We want everyone's lives to be valued exactly the same. So that's removing this apartheid system. What we have now, it says some lives are worth more than others.
Right.
And people are treated that way as well.
Yeah.
And this idea that somehow like nursing homes are going to go broke. I mean, I think that's, there's no evidence of that. As a matter of fact, we see the opposite in terms of, not the opposite, but we see a reason that we know that we're going to have more money into the system. And that is we are removing the for-profit. We are removing the administrative costs. For instance, a Kaiser would no longer have a CEO that we pay $15 million to. Kaiser employees would no longer have to be going out on strike right and left to get paid properly. So there are a lot of benefits to the system. Once you remove the differences, you remove the fact that we are put in separate categories. Good healthcare is getting exactly what we need, when we need it, in the way we need it. And we are not getting any of those three things guaranteed in the system that we have now.
Because I want to make sure that because in other countries I've studied, other countries' healthcare systems, their fundings get cut like every year. So I want to make sure that the AB 1400 has a sustainable funding formula or a lockbox, because I know
I'm predicting it does, because I'm just going to interrupt you here because maybe somebody else has a question too.
Sorry.
It does, because as I said, if the funding is cut, that means the governor's healthcare is cut.
Right.
And your state senator's healthcare is cut.
Right.
And the CEO of Kaiser's healthcare is, there won't be a CEO of Kaiser, but the CEO of, say, some industry, theirs will be cut. We would all be treated the same. And that's the beauty of AB 1400, is that we are, no one is safe unless everyone is safe. We know that health and illness are political, and we know that for all of us to do well, everyone has to do well, right? All boats rise with the rising tide. So, does anybody else have a question or something?
I wanted to show one more slide real quick. Is that okay? Let me just work on one thing.
And after that, we Jeffrey Tartagula has a question.
Okay. see, I can't seem to put it on again. God. So I close it, open the share screen again. Close it.
And then you select the image that
Okay.
you want to share.
Okay, there. Can you see it?
Yes.
Okay, this is a chart. It's self-explanatory. I'll make it real quick, but it's a comparison of single-payer Medicare type, all type system countries versus the US. You'll notice at the far right, the deaths per 1 million people. And this is the difference between having a single-payer system in the United States. So if you add up all of the deaths per 1 million people on the right-hand column of all the other single-payer countries, the 6 of them, and you average it out, okay, it comes to about 261. That's 11% of the US death rate. So this is not very scientific, nor is it going to be accurate. No one can really give you an accurate number. But just for purposes of numbers, if you were to extrapolate that 11% to California, instead of, what is it? How many people died? Instead of 71,852 people dying in California, maybe only about 8,000 could have died. So I just wanted to share that with people.
Yeah, those mortality statistics are very important because we know that in private equity nursing care facilities, that increases the short-term mortality of Medicare patients by 10%. So over the last 10 years or so, we've lost over 20,000 lives due to the fact that something is privately owned, that a facility is privately owned. This is also the measures for patient well-being are also declining, such as mobility. We know that in order to make money, that these privately owned nursing facilities, they skimp on care, they skimp on staff, and that's what they do to make money. And while this has happened, while the quality of care and the outcomes have declined and the death rate has increased, our taxpayer spending per patient has increased by 11%. So that money's going somewhere, but it is not going into the delivery of care. We know that.
Yeah.
So, any other questions or comments from people? Oh, we have people here. Wait, we've got, let's see.
Yeah, somebody had a question before I put that slide on.
Galleria.
Pardon me?
Jeffrey has a question.
Okay. And I think my colleague Taiji Miyagawa has also joined us.
Okay.
So sure, we can have the question right now. If you want.
Jeffrey, you want to unmute?
He's not there.
Yeah. Well, I guess William.
Let me just say, and I don't mean this in any way to be disruptive or to create tension, but in terms of our understanding of what we're after, we have to understand that Medicaid is utterly evil. It was created in order to not Bolshevize the American family and to fund facilities, even despite the waiver system. And we need to be talking about, in conjunction with 1400, a radical removal of segregated, congregated services and be thinking about what happens in most cases with people with special needs and disabilities, individualized planning that would deflect them from the requirement of having to go into congregate, segregated residential warehouses. My book that I just published, Public Hostage, Public Ransom, Ending Institutional America, lays out a harbinger of that with the big institution that I shut down with a federal class action lawsuit about crimes against humanity against the state of New York. But we have to begin to change the way we talk regardless of what's happening with 1400. There has to be an understanding that that model is purely corrupt from its start to its finish and dehumanizing maximally. Nobody should have to go into congregate segregated care. Nobody. we can make a difference with a different workforce and a different strategy and a different funding model. And that's what we're all about. We're about radical paradigm shift in healthcare financing and healthcare politics, and not some kind of intermediary where we have to apologize for or somehow massage something as evil as Medicaid into a continued service with a transformation if AB 1400 has a chance of passing.
Fantastic, Bill Bronston. Those are really excellent points. I'd like to call on some people who have been putting comments in the chat. I see from Sumitra, I see from Leland Young. Sumitra, do you want to say something about this?
Maureen, Jeffrey had a question. He's been
Jeffrey.
waiting.
Is Jeffrey on?
Yeah, Jeffrey, you want to unmute? Jeffrey, can you unmute?
When Jeffrey can unmute, he will get back to us. Jeffrey, when you can unmute, get back to us. So
Okay.
we also have our other co-host, Taiji Miyagawa. Taiji, you want to say hello and do you have any comments to make? Would you like to unmute?
Yeah. Hi, everybody. Sorry I'm late.
Welcome, welcome, welcome.
Sounds like a fun conversation.
Yeah, David just covered the bill, AB 279, and what happened to it. So
Okay.
we don't know if you have any further comments on the bill or on our way forward in correcting this situation so that we can have a decent healthcare system that.
Yeah, only that I think the campaign to try to win AB 279, which I'm sure some people had heard about, or hopefully David get a recap of what the intent of the bill was. Basically, it just, I mean, for the fight that the Save Our Seniors and the Japanese American community has been in, we lost the only intermediate care facility in the entire United States that had bilingual, bicultural care for Japanese American and Japanese seniors, right?
Yes.
So
that is a horror. That is such a tragedy.
the California Department of Public Health, controlled by private interest by way of the California Association for Health Facilities, which is basically the private operator lobby, they colluded with the ownership to evict all of the 80 to 100-year-old seniors out of that facility and force them into facilities that do not have the same level of care, right? These facilities were founded through the sacrifice of a generation of, out of our community, my parents' generation, because of the fact that healthcare in the United States is unequal, right? And bilingual, bicultural care is not acknowledged by the legal system as a necessity for delivery of healthcare, right? So there's not really any strong legal grounds to fight for it. Like, we've been trying to get lawyers to support us, you know, like on a discrimination type level, case type level, and we haven't been able to do that because they know that the system, you know, legal and political system just doesn't back that up. So it's a pretty major loss for us, and that's why David and I and PANA people within the Save Our Seniors network are pushing for AB 1400, because for the first time, as far as I know in U.S. history, a major healthcare reform bill in a major state is actually addressing precisely this issue of the necessity of multilingual and culturally appropriate care. So, I mean, we're really excited to be supporting the AB 1400 and to be on this call with you folks, largely because for the first time, it's like, hey, we have a healthcare reform bill that's actually, as Maureen has said before, that is actually for all. It's not just for, you know, it's not to the exclusion of people that don't speak English, right? And so it's really exciting. So our task in the Japanese American community, and as PANA members in other Asian communities that are majority an immigrant population, is to get the word out that, hey, you know, the fact that 25% of Koreans don't have health care, the fact that 20% of Vietnamese people in the United States don't have health care, we can start addressing this, and we can specifically start advocating for the need for bilingual, bicultural services if we support and win AB 1400. So that's, in a nutshell, there's the bad is we lost AB 279, which was statewide going to try to prevent the evictions of seniors from licensed senior care facilities. And for us, it was going to open up the door with the Attorney General's office possibly to reopen. We're still going to try to do this to re-examine the original conditions of sale of these facilities that were for our community that were taken over by this real estate developer. We're still going to pursue that, but it makes it a little bit harder because we didn't get AB 279 passed. And for the AB 1400 fight, I think a couple of things. I mean, even though the bill isn't as far-reaching as AB 1400 seeks, we were able to, get bipartisan support for the interests of seniors in California with 95% of the legislature. And it just kind of speaks to how the governor's office is heavily influenced by corporate interests. So we're going to have to build a lot of grassroots power to contend with that, going forward. But we think that the work that we've done in Save Our Seniors and the networking we've done with other senior care reform activists and organizations statewide really kind of is going to help us, going forward, hopefully with the AB 1400 fight and, conversations like this one tonight to try to extend how we can address the issue of inequality, which I think is essential to broadening the grassroots power that we're going to need to win, healthcare reform, healthcare for all in California. So I really appreciate this conversation and this space. Thanks for having me, even though I'm late.
Thank you so much for the input. And yes, everything we do to move forward is an advancement. Every inch forward is a success. I always look at the compensation end of things, and the administrators, for instance, in the California Department of Public Health, that's Thomas Aragon now, they are appointed by the governor and they serve at the pleasure of the governor. So there's this incredible relationship there where these guys, like the chief of the Department of Public Health, his compensation is $275,000, and that's a nice job. But he serves at the pleasure of the governor, and anyone who displeases the governor probably isn't going to serve very long. So there's this like incestuous relationship, I think, that prevents some of the autonomy and the independence that we would really need in a public health department that is truly dedicated to public health. One other kind of interesting thing, I just for fun, I wanted to mention, and that is the Department of Public Health actually has a position, a paid staff member, Robert Glazier, who is in Communications and Government Affairs Executive. And his job is to improve the credibility and reputation of the Department of Public Health. And he claims to have a track record of successfully getting political legislation passed, successfully delivering spectacular results and credibility enhancement. So that's kind of interesting that a public health department has to hire someone to enhance their credibility and their reliability and, how much people trust them. So just a fun fact there. We do have some questions here and some comments. I didn't know, we have Leland Young, we have Sumitra.
Michael Pan has a good question.
Who does?
Michael Pan has a good comment.
Okay. Would you like to read it?
Yeah, I'd like to actually respond to it because he says that Japanese Americans and other ethnic groups need to create their own hospitals, nursing homes, and home healthcare agencies to address discrimination based on race and ethnicity. And I think that's a very interesting comment because, Michael, that's what's been happening in history. Like in the last pandemic, 1918 in Los Angeles, most people of color could not get healthcare at that particular point in time. As people know, during those times, you had all kinds of things like anti-miscegenation laws and all kinds of horrible things. So people just did not get healthcare, and they're dying left and right. And that's the period of time in 1920s that Japanese Americans put together their money and created Keiro Nursing Home, which was a nonprofit. So we did that. And many other people, I know Native, indigenous folks, African Americans, people created their own health clinics and networks with their own money and community. And that's what you do when the powers to be will not give that to you. However, what happened was that it went on for, long time. And about 5 years ago, the nonprofit called Keiro, which was a community icon, because it had bilingual, bicultural care and, everything like that, it could not compete with the with the profit making hospitals. It's like having a small mom and pop next to Walmart. Okay, it's the same thing. And they're going broke because the Walmarts could completely outsell you. They can get all the staff, pay them cheaper than you, yada, yada, yada. So you're not going to make it as much. Okay. And based on that reason, they sold it to Pacifica, the big developer. That was the excuse that they used. So if Japanese Americans were again trying to get a nonprofit, nursing home for themselves, they'll wind up with the same problem, except now the competition will be even much more worse because the Walmarts have gotten bigger and the mom and pops have gotten less and less. I think profit is now 88%, with nonprofit being only 12% of nursing homes in California, and it's getting worse. So therefore, if AB 1400 were to pass, even if people in the Japanese American community, even if people in the indigenous community were to somehow get their own nonprofit nursing homes, AB 1400 would assure that they would be able to survive a lot better. And the reason for that is because the margin of profit for the privates will be cut back. So therefore, they would be able to stand a lot longer with the privates.
Yes, I wanted to tag on to that. Yes, AB 1400 guarantees that the same amount of money paid for care follows the individual. Right now, we have healthcare deserts. We have places like South Central, where you're right, the monopolization and the consolidation of facilities has led to the closure of so many clinics and so many hospitals across the country and in our state. What happens is when a community relies on Medicaid and also uninsured people, the facilities there cannot stay afloat. They cannot afford to continue. For instance, we had a hospital in Linwood, I think it was St. Francis. St. Francis delivered more babies than any hospital in the entire state, like 5,000 babies a year. But it couldn't stay open because it had served an emergency care. They gave a lot of emergency care. So they served so many undocumented people or uninsured people, let's put it that, it's uninsured people. And they also Medicaid patients. So they couldn't afford to stay afloat. They were bought out, and immediately what happens is services get cut. What are the most expensive services? OBGYN, let's cut those. Labor and delivery, let's cut that. Emergency, let's cut that. They just remove whatever isn't profitable. And with this monopolization and consolidation is also a nightmare for senior care facilities. For instance, there's one national company called Genesis. It's a nursing home chain. They operate 400 facilities in 26 states nationwide, and they provide rehabilitation in another 1,400 locations. Now, Genesis has settled numerous multi-million-dollar lawsuits for financial and care violations, but they're still operating, right? So when the Centers for Medicaid and Medicare changed the national reimbursement rules last fall, they lowered the compensation for therapy, right? So the for-profit company promptly just laid off 585 of its staff therapists. So this is what we've seen all across the country in a crisis like COVID. We see hospitals closing, We see staff furloughed and laid off. So this is why we cannot have an apartheid system where people that live in South Central carry fewer dollars with them when they need care. There's something beyond the healthcare system as well. When we invest money in an area, for instance, if we could reinvest money in hospitals and facilities, which AB 1400 does, it equalizes the access to care across the state. This will benefit rural and urban center hospitals because money will start flowing in. That creates jobs. That creates other businesses. Look around any hospital. Hospitals have other businesses growing up around them. It will reinvigorate communities that are now desperate for not only their healthcare facilities, but opportunities for jobs are also diminished. In addition, you have more people who have had to delay their care or get substandard care, and therefore we have more disability, more people that have permanent disabilities that now can't work, and that further impoverishes an entire community. So AB 1400, by investing equally, by equally, I mean according to need, investing according to need, wherever populations have more need and they have traditionally and historically been disadvantaged, more money will be invested into them to bring them up to standard. And that's going to change not just our healthcare system, it's going to change communities, the economics of communities, and it's also going to change our ethic, our sense of morality, when we finally agree that all people are equal in one of the most basic services of all, which is healthcare, the delivery of healthcare. Right now, we don't have that belief in this state. AB 1400 would, push the limit on that and say, yes, in fact, everybody is equal. Okay, we do have some questions.
Mm-hmm.
Sumitra, did you want to say anything? If you do, unmute. If not, we'll go on to Leland.
Oh, just can you hear me?
Yes.
Okay. Just to read what I posted, I'm not sure if the link.
Go ahead and read it because when this session is posted on Facebook, we will not see the chat.
Oh,
so it's good for you to read what you have to say.
Okay.
So it will be preserved for future reference.
Okay. Let's see. Okay, so essentially, just to talk about nursing home problems in general, approximately 75% of American nursing homes siphon money from the facility using a complicated corporate web of related entities. This also includes the nonprofits, not as much, but they do this, where essentially what that means is that owners of nursing homes, they outsource a wide variety of their goods and services to companies in which they have a financial interest in or that they actually even control. This is very common. It's rampant. This is one reason why close to 200,000 nursing home residents and staff died, because what they do is and then they demand more money from Medicaid because they don't have enough money because they're giving it all to their other, this is a shell game essentially, to their other contracts. They artificially create high level contracts with these other entities that they actually own or control. And then they shout, fire, fire, we need more money. When actually what they're doing is just cutting, they're not paying staff, they're cutting staff. So, I'm sorry, I'm going on a little bit too much, but
that's okay.
if you have any other questions, I don't know if I can answer all of them, but.
Does anybody have a question for Sumitra?
Yes. Oops. I do have, if it's okay.
Yeah, I don't know if I'll be able to answer, but go ahead. I'll find out the answer if I don't know it.
Okay, yeah. I had this, a common question, and that because you mentioned that Medicaid is considered a welfare program, not a healthcare. I mean, not part of the healthcare budget. I think I understand why it's considered separate, because if you go back to the pre-1965 Medicare, Medicaid that L.B. Johnson passed, you'd be very surprised. Who actually wanted Medicaid to operate from Medicare is actually the AMA, the American Medical Association. And they added Medicare parts A, B, and C onto Medicare because physicians at that time knew that if Medicare was going to have complete control of how doctors get paid, they would earn less and boycott the entire healthcare industry. And that's why we have this kind of policy by design. It could be undone if we have the will. So that's why why Medicaid patients don't end up in why their healthcare outcomes are much lower than patients on Medicare. It's because by design, race, socioeconomic status, geographic region. And my question is that because I know that, the Affordable Care added too many, it's great the Affordable Care Act reduced the number of uninsured. However, it maintained the institutional control over patients, doctors, and healthcare providers. And my question is, if we go into Medicare for all, would it eliminate the, like you mentioned, the PD something, the PDMH?
PDM, yeah, the
right,
value.
PDM, right. Will it eliminate that? Eliminate a lot of hurdles, because I come from a medical, I come from a family. I'm sorry, my dad's a doctor. He works in solo practice for over, about 33 years. And he's staying in the profession, but a lot of his colleagues have left, or they're thinking about heading for the exodus, with more reforms coming in, changing in payment models, reimbursement rates, because they want to make sure that they get paid, not only fairly but adequately based on their work, education, and training, because they don't want to go through so many hoops in terms of documentation. Because if they document that the patient was in moderate health, Medicare, especially Medicare for health insurance, I know that's not enough. We need more information or upcoding.
Thank you so much, Michael. You hit on so many important topics. And yes, I wanted to address or mention the frustration of so many physicians is the fact that they spend 20 hours a week on average personally dealing on the phone with the insurance industry, obstacles to giving their patients care. If we had an AB 1400, if we had something like that nationally, which would be HR 1976, which is Jayapal's bill. AB 1400, the California bill, is modeled after the federal bill. But it has been determined that if physicians didn't have to spend the time that they do dealing with the insurance industry, and with AB 1400, they wouldn't, they would save nationally, we would have 846 million physician hours freed up for care. So physicians could do what they were educated to do and what they want to do, which is take care of patients. So right now we have 846 million hours a year wasted on unnecessary dealing with insurance industry obstacles to patients getting care. And we had one of our wonderful physicians, Dr. Richard Wynn, who's a pulmonary specialist. He told us a story about how it took him 2 months to get a prescription approved, a life-saving prescription approved for one of his patients. And by the time he got the prescription, she had 2 weeks before gotten the medication from Canada. So after 6 weeks, she'd had enough and she got the medication from Canada because her own doctor here in the United States could not get her that medication. So these are the ways in which physicians are frustrated and obstructed. And all those hours are billable hours, 846 million billable hours for taking care of patients rather than dealing with frustrating conversations with those trying to obstruct the care. We do have some other people.
Maureen?
Jeffrey. Oh, I'm sorry, Sumitra, go ahead.
Yeah. Did I don't know the other speaker's name.
Taiji or David?
The one that was just, was wanting to ask, did he ask me a question or did you?
Michael Pan?
Yeah, I wasn't sure if I answered the question.
Yeah, yes. I think
he said he had a question for me, but I didn't hear it.
Oh, so. Yeah, because you said earlier that that you might be able to answer my question, and I think by accident, the host probably transferred me to what's it to Maureen Cruz to answer my
Yes.
question. So I'm not
Oh, okay.
yes.
We do have a stack of people on Facebook asking questions, so let's list
What are the
the
questions?
stack. First, we have Jeffrey. Have you been able to unmute yet? Jeffrey Tardagala? No. Okay. In this order, James Forthman, James Sorrentinos, Jeffrey, again, Betty Dumas, and Gina Curry. So James Forthman, have you a question or comment? Unmute.
The questions in the
Oh,
chat.
Oh, it's in the chat. So will you,
You want me to
oh,
read
it's in
it?
our chat?
Yes.
Oh. So wait,
You want me to read it?
Yes.
Okay. James Fortman from Facebook asks, should also address healthcare for rural residents lack the resources to get adequate healthcare on oftentimes.
Yes, AB 1400 solves that problem because AB 1400 will invest money in the rural communities so that someone living in a rural community will have the same access as someone in an urban community. And also allows physicians to move to a rural community. If they choose to live in a rural community right now, it's difficult for them to do that because they can't afford to move to any community if the majority of patients are Medicaid. So, and unfortunately, in a lot of rural communities, that there's a high percentage of people on Medicaid. Okay, next person, James Sorrentinos.
Yeah, James is in the chat and he was one of the original questions. Let me get to it. It's way up at the beginning. Won't AB 1400 stifle competition? Oh,
Would anyone else want to answer that? If not, I will answer it. It actually will enhance competition for quality of care. Because it removes networks, people can go to any facility, any hospital, any physician, any physician's practice that they choose. So in fact, the competition will be a race to the top for who can provide the best quality of care rather than a race to the bottom for who can get as much money out of the system by reducing care. Because in a network system, as we know, we are forced into a situation where we have no choice. And by the way, we even have less choice than we think. Right now, the city of San Diego is suing 3 insurance companies, including Kaiser, for misrepresenting their provider base that they have. And for Kaiser, and I believe it's Centene, I'm not sure, I think it is Centene, 35% of their provider lists that they offer in San Diego do not exist. And there was another company, I'm sorry, I'm blanking, and I think it was Molina, but let's say another insurance company, 80% of the providers that they claim that they have when they get people to sign up for them do not exist in their networks. So these network provider lists are woefully inadequate and inaccurate. So we wouldn't be seeing that anymore because we wouldn't have networks. Next question.
yeah, Jeffrey posted in the chat 2 things. The last 2 elections, 40% of the population voted no, which you can, and then he continues, another one. I don't, that wasn't a complete question, and I'm sorry, I don't know how to unmute him. Governor's last 2 elections, only 60% you need to convince at least 20% to get 66% for a tax increase. You only have 49% ready to pay for this. So he's basically, I guess, saying that we need more people who want to pay the progressive tax, but there is no progressive tax set up yet, is there? So, and that's to be decided by the assembly, correct?
Yes.
So Jeffrey, I think that's what the answer is. There isn't yet. I wish I could unmute you. I don't know why it's not unmuting. But anyway.
Then there's Betty Dumas Toto.
She just wanted to say, let's see, let's find it. It's in the chat, by the way, too. So let's see what she says. I think she was agreeing with.
So it's not a question.
Yeah, it's not a question.
With respect to the money question, I've been asked that. So, well, what are we going to pay for? Yada, yada, yada. I deal with it. I just say, you know, right now for a family of four, it costs about 10 grand roughly a year. Okay, so you may pay a couple hundred more, but you're going to be 9,700 in the black more. Okay, because if you're paying 10 grand right now, okay, let's say you pay 300, you won't pay the 10 grand. So that's basically what I say, which is, and that's not that far from, you know, the real numbers, actually.
Right. Yes, correct. I always tell people that on average, we are paying $11,000 per person in this country for health insurance, and 70%, 7,000 of that is already tax dollars, and 4,000 on the average is out of pocket.
Right.
When you look at countries with single payer systems, they pay between 4,000 and 5,000 in taxes, and then that's it. Except a couple of countries, people will pay less than 1,000 out of pocket. So we're paying 11,000. Most countries are paying around 6,000 maximum, but most of that is their tax dollars. We are already paying almost double in taxes alone what people in other countries pay in taxes. We pay about 7,000 per person. They pay 4,000, and then they're done. But we have out of pocket, and we also have unpredictable costs, right? We have no idea of what we're going to have to pay. Okay, were there other questions?
But don't run away from that question. I know a lot of people get freaked out. A lot of people run away from it. A lot of people don't want to talk about that pay thing, but that's what people want to know. And if they sense that you're afraid, they'll keep pursuing you. So don't freak out. Just be sure.
That's very good, because it really is a very clear-cut answer. The fact is,
it's very clear.
Yes, you know, you will not pay anything out of pocket. You will pay no premiums. You will have no deductible, and you'll pay a couple $100 in taxes.
That's the answer.
Nothing will come out of your pocket. You know. So, Leland Young, did you have something to say? If you're still there, Leland. Nope. Leland?
Okay, I'm back. I'm sorry, I was just busy for a second.
That's okay. Did you have?
I was just talking to a friend about long-term care, and I was talking about that. I explained that that Medicare for All would cover long-term care, and she said, "Well, it doesn't matter, because what she'll do is use up all her savings and sell her house, and go broke, and then get on Medicare and get in some government system." And for some reason, I couldn't talk to her about that, but it seems like what Maureen said about where we actually pay more in taxes already than countries that have healthcare for all. So I think with SB 562, they said the average person would pay $562 a year for healthcare, and it would include long-term care. I think I probably pay almost that much a month. So for a whole year, it's $562 a year for the average person. So I think for Asians, at least for me, that's an important thing. But I don't see why that's not emphasized, because I'm raised in an environment where I had to work when I was a child in my parents' restaurant, so I count money all the time. So I think that's an important concept to tell people that we'll actually be paying less with and a lot less with Medicare for All. That's all. Oh, well, I do have one question. Is that it seems like it's really hard to still get past it. I'm trying to work on it for 4 years. But what Michael Pan was talking about with having Asians having their own different care or something, is there, I've seen like in LA, the healthcare for LA, they do things like food banks and things like that. So it still seems like maybe if we do things like that with the food banks or something, the people that are working for Medicare for All, they get some feeling of success. They're actually helping people too, rather than just lobbying for something that doesn't seem to pass. So maybe that can keep people that like to help people going instead of just constantly failing. Like in the Bay Area, we seem to always work on political things and doesn't seem to work. So, so I'm wondering, is there a way to do things where we can actually do something as a volunteer or do things that can help people immediately right now?
Yeah, I think you're talking about solidarity across issues. And I think it speaks to what the poet Audre Lorde used to say, is there is no single important issue because we don't live single issue lives. So I know with Healthcare for All LA, we value our allies and our partners, each of whom has different priorities, although healthcare is involved and of course at the base of many of them. But yes, you need to get involved. For instance, DSA LA has a wonderful healthcare justice committee that we are involved with, and they have mutual aid projects. You know, we were pleased to be partners with Save Our Seniors effort and show up when we could, because we saw that as very, very important. So yes, just look around. There's plenty to do across all issues. But the thing is, solidarity, outreach to partners, build allies, work together, respect one another's priorities, and help each other. I mean, really, that's David or Taiji, do you have anything to say about that?
I'm gonna talk about what Leland was addressing. I mean, I think it's something that requires a lot of work, but like we've been out of Progressive Asian Network for Action, we have been doing a street walk effort in response to the anti-Asian violence that's been sweeping the world. And we do a street walk every Thursday night in Koreatown, half a block away from where a 30-year-old Korean veteran was almost beaten to death. And we're interfacing directly with community, small business people. We're visiting some senior homes in Koreatown, handing out, you know, supplies, whistles, pepper spray, informational booklets about how to report hate crimes. And we've been framing the way that we talk about the issues to kind of try to link it back to issues like the evictions at the Sakura Intermediate Care Facility and the demise of the Cairo nursing home facilities at the hands of private operatives. In the way that we talk about it, we say, you know, there's different types of violence that are delivered towards Asian people, and one of them is discrimination in healthcare, right? You know, I mean, evicting a bunch of seniors for the second time in some of their lives at the hands of the government, right, because they're Japanese Americans, is pretty violent in the middle of a pandemic when there's not even a vaccine for the Delta variant. I mean, here's how ugly this fight with this recent CDPH around AB279 was. The families presented a spreadsheet of all the nursing homes in the Southern California region with check boxes as to whether or not they met the same level of care that the ICF was giving, right? And they knew, the CDPH knew there weren't any comparable facilities to send these residents to, right? Not only that, the Sakura ICF facility was like the shining model for all senior care nursing homes because it had been kept 100% COVID-free during the duration of the pandemic up to that point, you know, when the CDPH gave a green light to the mass evictions of that facility, right? So, I mean, that's pretty violent, you know, that's pretty violent. So I think the way that we talk about the issues, I think, is important. And then, so joining a food bank type program that's serving like, you know, underserved communities, or another instance where I've been trying to talk about it with some of the housing activists that I have histories with is I'm trying to like get them to look at AB1400. It's not narrowly just like this healthcare bill that the healthcare activists deal with. AB1400 is also a housing bill, right? I mean, if you read the bill, and that's why we're talking about it here, by specifically saying that we should have public funds invested in underserved communities. For example, in the case where there's a need for bilingual and multicultural, culturally appropriate healthcare, Well, that's facilities, infrastructure development, right? That's capital investment to build facilities in those communities where they're needed, like Maureen was saying in South Central, right? And in some cases, that's going to be senior housing. So AB 1400 is not just this side silo that housing activists shouldn't pay attention to. You know, they always go around saying, well, housing is a healthcare issue, because if you're a senior or a person on fixed income, a senior on Social Security, you shouldn't have to be forced to choose between paying rising rents or splitting your overpriced pharmaceutical pills in half, right, in order to survive month to month, right? So if the housing activists can talk about housing as a healthcare issue, they should be able to get behind AB 1400 as well. And ditto for the environmental justice people. You know, like, I mean, we work with environmental justice people. So environmental injustice, of course, it's the whole phrase came about because of the disproportionate impact of toxins and pollution, right? Well, that's clearly a healthcare issue. So those environmental justice activists should stop looking at AB 1400 as a healthcare issue separate from the healthcare context that they're trying to talk about with environmental justice, and they should be getting behind AB 1400. So a lot of this reframing and breaking of the silo mentality and the social justice movements has got to be there's a lot more work that has to be done about it, and I think AB 1400 really gives us a good opportunity to start breaking down those walls. And I know that Healthcare for LA has made attempts at that with doing Zoom calls about environmental justice and things like that. And I'm glad today we could talk a little bit about, the housing angle from the senior healthcare angle.
Thank you, Taiji. That is so true. At the very base, AB 1400 says all lives are equal. And healthcare is more than medical care. Healthcare is getting what we need, when we need it, in the way we need it, to stay healthy, to be the best that we can be. So it's more than medical care. And yes, that involves housing, it involves food security, it involves environment. But at the very base, we need something to change the unethical and immoral system that we have that says all lives are not equal. If we start with a healthcare system with all lives equal, in European countries, it has been shown that when they have equality in their healthcare system, every other metric for every other social issue and every other social determinant of well-being improves. Everything improves. Because at the very base of it, if we're all paying for the healthcare and it goes through the state, it's to everybody's advantage that we all be healthy, right? But right now we have a sickness culture. It's to the corporate advantage that we be sick and that we, are kept kind of trapped in this system where there's really no way out. We have to choose one thing about staying alive instead of another thing that we need to stay alive, right? And it is true that there is a percentage, and I'm not sure what it is, but I know there is a percentage of people who lose, who end up unhoused. 500,000 foreclosures on homes are, 500,000 bankruptcies, that's right, are due to healthcare, to medical debt. And that's something we don't talk about. Medical debt, as you said, it forces people to choose between food and housing, or food, medicine, and housing. Well, medical debt is unheard of in single payer countries. They don't know what it is. If you say your deductible, they say, what's that? If you mention the premium, they don't know what a premium is, because they don't deal with any of these things that divide us into, those that are more financially valuable, what is called human capital, right? We're called human capital, or IGUs, income generating units. We're not even called human beings in the language of the insurance industry. So I'm really glad that you brought that topic up, because it's very, very relevant. And yes, we need to break down these barriers because that's the way the corporations win, is to put us into boxes and say, well, you just deal with the environment and you deal with housing and you deal with food. And no, everything is related. Health care, health and well-being is more than medical services. It's everything we need to live. So I wanted to share, go ahead, David.
Just on that point, I just want to share a short story. This most recent efforts by the California Nurses Association to come up with 1400, before that was 562. It kind of started about 12 years ago, 15 years ago at Long Beach Memorial. Nurses were organizing there, and they're also organizing at Little Company of Mary San Pedro, as well as Long Beach Memorial and St. Mary's, all three places. One of the biggest complaints was workload. Okay, it's just too much work. But when you examine the type of workload, you know what it was? It was people with respiratory illnesses coming in that were much younger than before. So this was like bringing in, Long Beach, as you all know, this is like nothing but refineries, right? So what happened was that, interestingly, some of the nurses who were very conservative about things like environmental issues and things like that, they started getting very concerned about their own workload. And because of their concern about workload, not the environment, but the workload, they started complaining about how come so many people are coming with respiratory ailments. And they started looking at the refineries. And that's why there was sort of a united effort among not just people who were concerned about the environment, concerned about their patients, and they're pro-union, but the anti-union nurses were concerned about working too hard. And so that attracted them, and they became slightly a little bit more political and concerned about the environment because of that. But I just want to add that, and that kind of snowballed into CNA pushing for legislation on single payer.
That's a great story because everything is related. I wanted to share a few statistics with everybody because we started out talking about senior care facilities and the travesty of a political system that doesn't allow the people to be represented and have our needs met. But we will all, most of us will be needing special care, long-term care. And if we ourselves don't need it, our relatives will need it, our parents may need it, our brothers, our sisters. So 70% of the population of this country will eventually need long-term care. And it's expensive. The average lifetime cost is $260,000 to get the care that you need in the system that we have now. 25% of children are providing caregiving for their parents. That's $3 trillion in lost wages. People have to leave their jobs in order to care for their parents. It's $3 trillion in lost wages, pensions, and Social Security that we're losing because people cannot continue to work and leave their parents bereft of care. The average retirement age for savings, the average retirement savings, for those 65 and over is $148,000. So much more than what people save their whole lives will be expended in, taking care of them after when we need it. So Medicare only covers short-term nursing home and home health. And people have to pay out of pocket until they are poor and Medicaid eligible. But then as you see in the caste system that we have, when you are a Medicaid patient, you have a harder time finding care. You have a harder time finding a residential facility that will house you. You have discrimination across the board in trying to get access to care because you are not valued as much as someone on Medicare. So what will AB 1400 do? AB 1400 includes all ages. So those of us, when we're younger and we're healthier, we will be paying into a system and not taking out of the system. But when we're older, that money will be there for us. So AB 1400 reduces administrative costs. Instead of having, 1,500 or 2,000 different healthcare plans, we will all be in the same plan and the same system. AB 1400 protects and pays informal caregivers. We know that one of the things that actually paying people more and giving them benefits, these people that are working in nursing facilities, nursing home facilities, actually saves money because it prevents a lot of the hospitalizations and the emergency room visits because people are better taken care of. So we need to not only pay our caregivers more, but we have to hire more of them so that there's a decent ratio. And I know California nurses, they know that in the hospital, how important the ratios are. AB 1400 ensures equity, and areas that need more are going to get more. The point of a healthcare system is to serve the population. So whatever the populations need, they need to get. Instead of having, within 10 miles of my home, having, 5 hospitals, and then in South Central, you can't find one for 5 miles. This will help people get the access that they need. AB 1400 controls finances. Beyond the insurance industry, will also do what Medicare does, which is tells hospitals, this is what you're going to be paid for this service. This is what you're going to be paid for this bed. There's not going to be any more of this profiteering of what David Belk, who wrote the book, The Great US Healthcare Scam. And he has a blog called The True Cost of Healthcare, well worth looking at. He talks about how hospitals, he has 2 patients in the same hospital with exactly the same diagnosis, and they need the same treatment, and they have the same physician. He's the physician. One is charged, $25,000, and one is charged $5,000. So it's just a complete, a complete mess because people are charged different amounts. So it covers, AB 1400 covers long-term care for all disabilities and all ages, because the point is to meet your physical, mental, and social needs. AB 100 supports civic, social, and economic participation, because these advisory committees bring in, the bill has advisory committees that has people from all areas of the healthcare, sort of the healthcare soup, I'm going to call it that. It prioritizes home and community-based services over institutional services to correct the institutional biases that exist. If people will have a choice. If they want to stay home, that care will be provided for and paid for. If they want to be in an institution or a facility, they can make that choice too. It returns the autonomy, the independence, the judgment, the choice to the patient. And all decisions are made between the patient, patient's family, and your primary physician, who you choose, who you trust to work with you. It allows the independence and the dignity for those that have disabilities, and doesn't make people feel like less than. The accessibility across geographic regions, we've mentioned many times. And just the whole idea that there is this self-direction. Anyway, those are the ways in which AB 1400 helps solve the problems in this system. It is the solution. We're seeing a lot from other groups like Health Access and different variety of foundations offering us little band-aids. Oh, this group can get this improvement, and that group can get that improvement. Those are band-aids for cancer. And when you put band-aid on a cancer, it doesn't go away. It just metastasizes. People might feel better because the band-aid's there and they can't really see what's going on. But the reality is, whatever is under the band-aid is going to continue to get worse and worse. And we have seen that in the last several decades in this country with our healthcare system. So another point is half the population now that needs long-term care is under 64 years of age. 46% of the people who need long-term care now, who need some kind of extra extra care, 46% are under the age of 64. So anyway, and the home care, right now, with people having to stop their work, not only losing that amount of money, the 3 trillion, is that 30 billion hours of informal care worth $522 billion are now done for free by family members. So anyway, those are just some points that we need to equalize and the system, and we need to have a fair and just system that treats all people as equal, and we do not have that now. And the only way to treat everybody equally is to treat everybody equally. There's like no way around it. You can't talk about equity and equality and not having a racist system when we say some lives are worth more than others, and it depends on how much money can be extracted away from you and away from your care for corporate profits. So any other comments, David or Taiji, before we leave? Nope.
Oh, I think you said it all.
Okay. Sean, are you on? Yes, Sean
Yes.
Broadbent.
Yes, I am.
So moving right along into what can be done. And Leland Young, we hope you will get involved with this. Sean Broadbent is from a DSA Los Angeles Healthcare Justice Committee. He's one of the coordinators, and he is working on the strategies and the tactics and the grassroots out in the streets movements that we need to get this bill passed. And he's going to tell us all about it, and I hope you will all join. And you can join remotely with some of this stuff. So, okay, Sean.
Thanks so much, Maureen. That's right. Hi, everybody. My name is Sean B. I'm one of the co-chairs of the Healthcare Justice Committee at DSA LA. Just wanted to talk with the group here, and then anybody who's online or finding this later after the fact. We know that AB 1400 CalCare is going to have critical hearings in key committees in January. That timeline is real tight. So to mobilize the support we know already exists, we're going to have to find a way that all of us can take action. So to that end, Healthcare for All Los Angeles and DSA LA have partnered on 2 actions that anybody can take, and that we can encourage our friends, family, fellow activists to take action to build the pressure that we know needs to be put on. So the first one is a letter writing action. We have a wonderful graphic here. Pass AB 1400, California Guaranteed Healthcare for All. This is a great handout that we're going to have out in the real world. It's a bit.ly, but where does it go to? Let me show you where this goes to, and I'm going to share the link to this as well. One moment. Screen sharing, new share. Here is the wonderful page that the bit.ly goes to. This is telling your assembly member to pass AB 1400 CalCare. The really cool thing about this, and a lot of us are used to this, we've seen other orgs do it, but this is the first time HCLA and, to my knowledge, DSALA are doing it. We have an automatic entry form on the side here. So you put your name, last name, email, street address, city and zip code, and it's going to automatically find your assembly member. You don't need to look it up. You don't need to already know who it is, though, you know, we hope you already know that. But it's going to have a pre-written letter that you will be able to edit, say in your own words why CalCare is needed. Now, for everybody else who is a part of another organization, you can see here that the action is sponsored by Healthcare for All Los Angeles and has additional sponsor of Healthcare Justice Committee at DSALA. So what's really cool about that is any other organization that has an action network can hop on this and help distribute this letter. And you can track the engagement with the letter process in real time. So it gives you the feedback on Is what we're doing and messaging to folks successful? Do we need to have a phone bank in addition to this letter writing campaign? What does your org need to do to motivate the people that you're already reaching out to send a letter to their assembly member? Maybe you can just shoot them a mass email and that will get them to. But again, you might need to host a phone bank where you call your member list and get them to pass a letter. And you know that a lot of our members already support this. So what we're doing is really just mobilizing support that already exists. Now, the other thing we're doing that is really cool is we're doing an in-person action. So that was an online action that anybody can take. But here is the action that we are going to be encouraging and signing people up for throughout the month of November and December. Let me get that other graphic up and share it with you. Share screen. We are going to be at the Hollywood Farmers Market every Sunday. This is the largest farmers market in Los Angeles. It's historic. People are used to turning out to it. And especially with the holiday season, this is going to get a lot of constituents here. So again, we're going to be promoting the letter writing process, where we are interfacing with people who already support single payer, people who already know that healthcare is a human right, and we're going to tell them how to take action on it. Because that's the most confusing thing for anybody, is what can I actually do to take action? So the first thing we're going to do is hook them up with this letter writing process. And the second thing we're going to do is ask them to get involved with either HCLA, DSALA, or both, with hosting their own canvassing and tabling. But we think that the Hollywood Farmers Market is going to be an anchor for this demonstration project of how anybody can go and do a tabling. We're going to do it first at the Hollywood Farmers Market and then demonstrate how anybody else can sign up and host one of these at a event center near them. We think it's going to be really compelling. And frankly, in the time of COVID, we think this is going to be a lot of fun. So we hope you'll turn out to it. We have a lot of other fun things planned throughout the next 2 months. But the letter writing campaign and the tabling at the Hollywood Farmers Market and other locations to be announced is all coming up and live right now. So hope to see you soon out there. And if anybody has any questions, please do feel free to reach out to myself. Or what time is the farmers market? David Monkawa, thank you. Farmers market is 8 to 1 p.m. So 8's a little early for me, but you are going to see me there. 1 p.m. I'll probably still be there. We have broken up it into 2 tabling shifts. So there's an 8 a.m. and a 10:30 a.m. We encourage people to consider being there for the whole time, but we also want to give you the option of choosing 8 a.m. or 10:30. You're a busy person, you're a dedicated activist, but you know, how much time can you commit on a Saturday? We hope you'll spend at least one Saturday each month, November and December, with us tabling for CalCare.
Sean, can you put the link in again for the not the farmers market, but the other one you mentioned?
Yeah, for the assembly member letter action, I've got that there, and I'll throw it into.
I got that in. I'm referring
well.
to. Were you referring to another canvassing of some form, or was it the assembly member one?
So I put in there the letter action, and then I can also put the tabling action if we need that.
Okay, I did both of them then. We're
okay.
good.
Yeah, I think we're covered. Thanks, Paul.
Thank you so much, Sean. Fantastic, fantastic. Do you want to mention Cyclivia as well?
All right, so we don't have a graphic to show just yet, but on December 5th is Los Angeles' largest open streets festival. It's not just Los Angeles, it's the nation's largest open streets festival, where they close off miles of roads where people can bike, people can walk, people can rollerblade, skate, whatever you want to do. It's open to you. It's a real fun time. And we're going to hold our own tabling at that event. We're going to be able to interact with thousands of constituents in South LA, stretching across 2 assembly districts where the assembly members have not yet signed on to AB1400 CalCare. So we think this is a great opportunity to speak with the constituents in their district as they're going about enjoying themselves, and then again, approaching them on this issue that they already support. They already know that healthcare is a human right, and they want to know, how can we actually guarantee it? Not just play around with the idea of access, but how do we guarantee that you're going to be able to receive care? Well, CalCare does that, and we look forward to speaking with them about it and introducing them to the 7 principles of CalCare.
Thank you so much, Sean. I wanted to mention a couple of other things that are going on. There's going to be a panel hosted by the Martin Luther King Drew School of Public Health for students and staff on December 18th, hosted by Bita Amani, who's a professor of epidemiology there. And we will have some people there talking about AB1400 and the intersectionality of that with other issues. And there will be, we'll have more of that information. It'll be 6 to 9 in the evening, and we'll have more of that information coming up in our newsletters and on our Facebook and on our webpage. And we also are going to be part of a panel. Oh, I'm sorry, that's November 18th. If I said December, November 18th. And then December 7th, 2 days after the cycling extravaganza, we have a panel that is going to be speaking to the Los Angeles area community college faculty members, staff, and students, once again, about single payer and specifically AB 1400. And we will also be addressing the union issues at that time. We have a really nice panel of 3 speakers. So those things are coming up, and we still continue. Erica is going to talk to you about another event that we're having. I wanted first, Barbara Commons, are you?
Yes, hi.
Hi, can you just take 3 minutes?
Yes, I can.
All right,
Sure
this is
can.
Barbara Commons, and Barbara's going to talk to you for just a moment, since we're on the senior issues, about enrollment in Medicare, traditional Medicare, how important that is.
Okay. Actually, what I came to talk to people about is what's happening right now. It's called the open enrollment period. And if anybody here is on Medicare, this is the time to check to see what your drug plan is going to be next year. All the premiums are going up. I've already checked. And by the way, I'm something called a high cap counselor. I volunteer to help people with their Medicare and Medi-Cal. So anybody that's on Medicare, and you can be on Medicare because of your age, or also people with disabilities qualify after 2 years to be on Medicare. So anyhow, every year, the drug plans change, the Part D plans. And the best way, the quickest, easiest, is to call Medicare. They're wonderful people. You can call them up. They're open 24/7. Okay, you can call them up with your list of prescriptions. They'll put it in the Medicare website, spin it through all the plans, and come up with the 3 least expensive. Okay, and this is important because every year, everything changes with drug plans. Everything changes. The other thing you can do is if you're in, there's 2 paths to Medicare. There's original Medicare, where you have Part A, Part B in a drug plan. And then there's the Medicare Advantage plans, okay? During this period, you can also make changes. If you're in an Advantage plan, you can switch to a different one, okay? If you're in an Advantage plan and you don't like the ID anymore and you want to do original Medicare, go back. I would say you might be able to, but there's a glitch because you may not be able to buy a Medigap. And a Medigap is a private insurance plan that picks up on things under Medicare Part A and B. So I recommend that you, if you want to do that, you get counseling to help you. And you'll talk to a counselor like me, you get about an hour. We're doing it on the phone now, and it's working out pretty good. And I'm going to give you the 800 number to call where you can find out the counselor office in your county. Okay, so the Maybe I should put it in the chat. Should I do that?
Barbara, also speak it, please, because we have
Yeah.
people on Facebook that won't see the chat. So if you could do both, it
Okay.
would be wonderful. Thank you.
Yeah, the high cap number or SHIP, it's also called SHIP in other states, is 877-839-2675. All right, and they'll connect you with your county high cap office or SHIP office. All right, and this is real important. If you want to make any changes with your Medicare, I recommend getting counseling first, because sometimes when people just up and cancel a plan, they can get in big trouble in terms of financial cost. And you want to be sure that you can do it safely, and that it and what your what your options are. Medicare is complicated, but it's only complicated because they privatize parts of it. The Part D plans and the Advantage plans are both the privatized part of Medicare, and they create lots of problems for people. So if you have any more questions, I'll put my email in the chat, and you're welcome to email me too, okay? All right, I think that's enough. What do you think?
Thank you so much, Barbara. You are fantastic.
You're welcome.
Barbara is also a retired registered nurse. So thank you, really appreciate it. And that's why we need AB 1400, because we don't want to have to deal with Medicare, Medicaid, and all the rest of these things. We just want birth to death coverage with our little card from CalCare. Lastly, before we thank our guests, David and Taiji, and so much for coming on and sharing the Save Our Seniors and the Progressive Asian Network for Action. But we have one more announcement, and that is our wonderful co-director of Healthcare for All Los Angeles, Erica Ferriston. Erica.
Hello. Oh my gosh, what a wonderful office hours. I wish I had been on it from the beginning. David and Taiji, so much heartfelt love to you both, to PANA, to SOS, to Chung Sim Lim for connecting us. Taiji, thank you so much for painting the big picture of solidarity. It's all intersectional. It is a housing bill. It is an environmental bill. It is a senior bill. It is a children's bill. It is a human rights bill. So thank you so much for everything. And there were a lot of wonderful actions mentioned. I hope everybody got it all, but if you didn't, you can join HCA LA, and we'll send it out in our newsletter or email blast. And that's bit.ly, bit.ly, HCALA join. So that's how you can join us to get information there. Sean, I saw in the chat, Robert Copland, he's joining us from Facebook. He wrote, we are trying to get a resolution for AB 1400 and Medicare for All in Sacramento, most likely the Sacramento City Council on November 16th. So I don't know if there's any, if there's a contact that you can share with him if they need support, because you lead a pretty great resolutions team. So if you can, I'd love for you to unmute and share with him and everybody where they can go who's doing that.
Yeah, so I think instrumental to us passing a resolution in 2019 for Medicare for All at LA City Council, and then this year for AB 1400 CalCare, has been Public Citizen. Public Citizen gave us a wonderful tool set, and they are partnered with the California nurses. Now, you've already got a resolution. So what I think would be important to connect with Public Citizen about is being able to do a blast to constituents, letting them know that this is coming up, and driving public comment, either written or at the time phoning in, so that city councilors are hearing from people on this issue. You don't want to miss the opportunity. And then whatever, email lists or other form of communication you have available to you, do let people know that the vote is coming up. Go ahead and create a short script for them, some key talking points on the issue. Those are easily found from the nurses on CalCare. They have a talking points sheet. So share the rap sheet with people that you're in touch with, and make sure you get a generous public comment in there, because that's going to be important. So reach out to Public Citizen, and then use the talking points handout from the California nurses for public comment. That's going to be essential to getting it passed.
Thank you, Sean. And also, Robert, if you're still listening, once that passes, move them to use their city council lobbying power to go to Sacramento and lobby for AB 1400. So thank you, Robert, for doing that. HCA LA has joined with Progressive Democrats of America and Progressive Democrats of America, California, to host a town hall on November 14th, and it is with Carmen Comsty. Carmen Comsty is with National Nurses United, and she actually wrote AB 1400. So this is a town hall you want to be on. You can go to bit.ly, bit.ly/CalCare Town Hall, NOV, as in November, and that's all lowercase. And again, we'll send this out in our email. I'm just trying to think if there's anything else. I want to give, well, I guess finally, if you liked what you heard today, put 5 on it. We could use that 5. To donate, go to bit.ly, bit.ly, HCALA donate. So please put 5 on it. And I want to give thanks to people who do work a lot of the times behind the scenes. The beautiful graphics Sean put up, those were done by Bronwyn Major. We're so grateful to her for all the beautiful graphics you see. She also leads our social media team with Brenda Gutierrez and Jackie Hernandez and Chang Sim Lim. And I want to thank Paul Newman for running our Zoom and doing all the tech, and Maureen Cruz, our director, who has kept this going and keeps it going. And with that, we are out of time. So thank you all.
Also, thank you to Barbara Commons.
Yes.
Thank you, Barbara. Yes.
Thank you, everyone. Thank you for all you're doing in LA. You're great. Thank
Onward, together, all of us. All right.
Okay.
Everybody, have a good night.
Have a good night. Thanks for having us.
Thanks, Sean. Thanks, everybody. David.
All right, take care.
And Michael Pan for sharing so much as well. Thank you.
You're welcome. Thank you. I enjoyed.
Take care, everybody. Good night.
Good night.